weight 110 kg Burley, very strong man, muscularly 1 day old RTA. Acetabular fracture, then fracture base of neck and fracture shaft of femur. It's not clearly visible, but it is there. If you look at down the film, it's very visible. So, it's not moving, Ashwini. Moving नहीं कर रहा.
Complex floating hip type of injury. Head is dislocated posteriorly. There is basi cervical like neck of femur fracture. I will go with the KL approach. Fix the neck with the either small 2-hole DHS or 3cc screws. Do open reduction. In same setting, I will either do plating. I think plating would be better for femur.
Okay.
And posteriorly, you can fix with the recon plate. Posterior column and wall is there. So either single stage or 2-stage procedure. So you can do open reduction and femur fixation in first. Then, but if you are doing all in lateral, then I think we can do in a single sitting.
I have
No,
a
sir.
different plan.
Okay.
Maybe I can put a supracondylar nail for femur with the DHS and go for the posterior fixation.
For DHS, you have to reduce that head also.
Posterior fixation. Supracondylar nail I can put fix the shaft and here.
Sir.
Because that would be then the knee in the spine position.
Yeah, so I think either you can nail it in either direction. What do you need to get the neck and the head reduced first? So I would go KL, reduce first the neck and then the joint, open reduction under vision, put in provisional wires, get the joint reduced. I need to study the acetabular fracture a little closer because there may be a wall fragment there. There's a wall fragment there,
Yes.
so that you may have to get out of the way to reduce the head. Then neck here, probably a DHS, or I could put in some provisional fixation and do an antigrade nail. So it would depend on how things are there that I'll decide. So because you're not going to be doing this on a fracture table, so maybe DHS and then a retrograde nail for the femur. So depending on patient's condition, decide whether you can do it all in one stage or 2 stages.
Then in the second sitting, we will address the acetabular
You have to reduce the hip, no? Hip has to be reduced,
So
it's
you will-
dislocated.
You will first do
First, do the address the femur fractures
femur fracture.
by the supracondylar nail, and in same sitting, sir, we will address also the neck fractures. After that, we will think about the dislocation and acetabular fracture.
Okay. That's okay. So, this is the CT.
पेशेंट का एज कितना था?
This is the 3D. There is a fracture of the anterior column. I mean, it transfers the posterior wall. Plus all those things which has already been discussed. We thought of, as Rakesh was telling, first fix the femur and then do the next. But we were for the one sitting only. But as the man was burly, heavily built, on the table we decided to, as Dr. John has told, we decided for just a straight to a KL approach. We did reduce the head. There was a marginal impaction. We elevated it and then grafted it, put the after posterior column plating, put a, posterior wall in position, provisionally reduce the trochanteric fracture, fix it with K-wires, and K-wires in such a position that it doesn't come into the way of anti-grade nail, and then we did a close nailing of that what we did. And anterior column was stable. We thought of doing a screw from close, but somehow we didn't do it, thought it's okay.
It's transverse with posterior wall, so I think there is no need to put an extra anterior column screw.
I didn't, that's why I said, okay, it's okay, no use.
Sir, how much time it will take to do this on the one setting?
I think it didn't take much time. Huh? 3.5 hours, I think.
That's nice.
So you have done nailing in lateral position.
Yeah.
Yeah, I think nicely managed.
Thank you.
One more case.
Now,
No more case.
what has happened? Let us discuss it further. Patient, now the acetabular joint space looks somewhat reduced, and here, although my original direction was quite okay, neck shaft angle, but it has, look at this, it has got reduced. While the patient is not, he told me he is not bearing weight, but might be he is a heavily built man, so a bit of, अर्थ हो गया? Then back out of the, so I dynamized it, put the screws back. There is a further reduction in the next section.
Instability. Yeah. It'll go further.
But original reduction was very good, fixation was good, the bone stock was good. But why it is happening?
That's why the DHS.
No, at the time of original fixation, the purchase of the screws were quite good, sir. And reduction was also very good. And we had, that's why, instead of just one screw like the PFNA2, I went for 2 screws that will give better stability. Still it is not holding.
What you did next, sir? So the next step, what happened?
Okay, this is the situation, patient is 4 months or
So
5
what is the
months.
message of this case, sir? What is the message of fixation?
Message ki, in spite of doing very good work, you can
So
get into trouble. Thank
difficult
you.
fractures will have complications.
So the message I think is that this is not the end. Operation is not the end. So result is the end thing, which we should consider. And now,
I would like to invite Dr. Ranjit Singh sir to kindly come and felicitate Dr. Rakesh Agarwal, boss. Next, I would like to, sir, I would like to stay. I would like to invite Dr. Anand Shankar, boss. Dr. Anand Shankar, kindly come on the dais. Charan, sir. Sir, Mahesh Prasad sir, kindly come and felicitate Dr. Rajithanan sir. हाँ सर, हो गया. We'll move to the last session before the workshop, that is the case discussion session. And the chairperson I would like to invite is Dr. Mahesh Prasad sir, Dr. N.K. Singh sir, and Dr. Ritesh sir is absent today. Case presentation is by Dr. Kumar Shashikant boss. Please.
So, good afternoon everyone. I will be presenting one case. So, this was a case of a 73-year-old man with the history of fall from motorbike. And you would like to read this X-ray from backside? Anyone? So, anyone please give the mic to Priyam? Sudeep? Sudeep? Would you like to read this X-ray? Okay. So,
Hello.
Priyam is there.
Sir, iliopectineal line is hello. Iliopectineal line is broken, and the posterior wall is also, sir, broken on the left side. And sir, I need more views.
More views. So, obturator oblique view.
Sir, anterior column also appears broken here, and the other Jude, sir.
Here is iliac oblique view.
Sir, the posterior column is also broken.
Okay. So, there is a break in iliopectineal line. There is large displaced fragment of quadrilateral plate, and medially displaced femoral head is there, and there is intact portion of acetabulum in its native place. Here is the obturator oblique view showing intact acetabulum in its native place and displaced femoral head medially. And this iliac oblique view showing displaced posterior column. So, here is 2D cut, axial cut. So, A fragment is anterior column fragment. Thus, A is anterior column fragment. This B is posterior column fragment. And here this one C, displaced quadrilateral plate. And impacted injury over there of the acetabular roof. And this area is retroacetabular area. Now here in coronal cut, we can see that there is medially displaced quadrilateral plate with femoral head, and also fracture line is going through the dome. Here is 3D cut, segmental anterior column fracture with intact anterior wall, large quadrilateral displaced fragment, and displaced posterior column transverse fracture. So, at this stage, what is preferred approach according to you? So, Aswani told me ki keep a simple case where our postgraduates can easily interact. So, Priyam, approach? Which approach?
Sir, I will, for posterior column, I will go with Kale approach,
Mm-hmm.
and for anterior, I will go with Stopas.
So, you want to do it with dual approach. Anyone else? Sudeep? Sudeep? Which approach? The Stopas only. Okay. So, Modified stopage approach was used with lateral window, and quadrilateral plate was reduced and fixed with infrapectineal recon plate, and entire column was fixed with the suprapectineal column plate. These are the oblique views. Posterior column was well reduced, and that marginal impaction was elevated, and with the help of this screw, this was held in place, along with bone grafting was also done there. It's not moving. Okay. So here it is 5-month follow-up, AP view, Zode view. And this is 5-month follow-up. So patient is able to walk painless. And this video patient sent yesterday. So he is able to walk independently. This is 1.5 year follow-up, and he is doing all his routine activities. So ACPST is commonly encountered in geriatric population, and the osteoporotic bone ACPST is commonly associated with an individual fragment of quadrilateral plate. And many ACPST fracture can be treated by modified osteopa approach with lateral window alone if posterior column gets reduced and stabilized. And fracture with low intermediate anterior column fracture can be managed easily by osteopa's approach alone. Thank you.
Thank you, Doctor.
One
Short of time, only one question is allowed. Only one question.
Crew, and actually what happens ki we have two approach. Number one, we are using one plate for anterior column and then putting one screw from anterior to posterior to the column. Second approach is you are fixing anterior column, and through infrapectineal plate you are actually holding reduction of quadrilateral plate along with that posterior column, and actually you can use one longer screw through the plate which can go and hold the posterior column in that reduced position. So that approach was done. So using infrapectineal plate for reduction and maintenance of that, but the prerequisite is that posterior column should be well reduced. It should be well reduced, only then we can use that plate, infrapectineal plate.
Okay. Thank you, Dr. Sasikant. Now
Thank
may
you,
I
sir.
request Dr. Ratnesh Singh to present his case. Dr. Ratnesh Singh.
Presenting one simple case. It is 52-year male. Mr. HP presented to emergency with the pain left groin for last 1 day in July 2018. There was no major comorbidities. This was the X-ray, 52-year-old male. So, what to do? Conservative or operative? First, this is the X-ray. Now the investigations. What investigation would like to do? Anyone want to answer? Okay. This is the Jude view you want to see. Anterior column, posterior hemitransverse. This is the CT. Entry wall combination, posterior column fracture. Entry column combination, posterior column fracture. Approach, anterior, posterior combined. How will you fix the posterior column? Infrapectineal plate, you want to say Stupa's approach. Yeah. But it is tough to fix with the infrapectineal plate the posterior column of this kind. It would be tough to fix with the infrapectineal plate. So it was done with the anterior approach, and the posterior column was fixed from the lateral window with single screw, lag screw. It was fixed. This is 5-month follow-up, fracture united well consolidated. This is a judged view, 5-month follow-up, and patient is doing reasonably good. Yeah, thank you.
My question, Ratnesh,
Yes.
can it be treated conservatively?
Yes, sir, initially can be treated conservatively. Later on, have to go for the THR. I would like that option better. Actually, these fragments tends to displace more when patient starts weight bearing. And the columns are, you can see in this view. Hip is not congruent, so there is high chances of development of osteoarthritis.
My question, due to case solved by Dr. John Mukhopadhyay, the so neglected case, they walk very easily. That's why I'm asking.
So that's a very different case. Don't compare. So there where here you have the acetabulum on top of the head. So if any incongruency will cause problems. Yeah?
Fortunately or unfortunately, sir, I think 80% of these cases are not treated these days. They are, you may consider that may have been treated conservatively, and they are doing reasonably good. But at some time after 2 year, 3 year, 4 year, even you can see the patient with gross osteoarthritis and they are walking. So that won't be considered as a treatment. If we consider a treatment, we should fix these fractures. In reasonably young patient, 52-year working patient, we will consider him a young one, young active one.
Thank you, Rajnesh.
There's also medialization, if you see that.
Yeah, medialization of the fragment posterior. Yeah, thank you, sir.
Thank you, Ratnesh. And may I call a next presenter, Dr. Prabhat Prakash. Dr. Prabhat, show your case.
So, thank you BOA and thank you Ashwini to giving me opportunity to present my case. So this is my first case. A 20-year young male sustained RTA leading to right hip pain and swelling with inability to bear weight over the right leg. And he was hemodynamically unstable because he has also sustained abdominal trauma. And there was no distal neurovascular deficit. So this was the initial X-ray when patient presented to me. So can anyone classify this case? So there is dome fracture. There is also transverse component in the acetabular region. This was the initial 3D CT scan. I classify this fracture as an anterior column acetabular fracture variant. So there may be chance of both column association, but on 3D CT it seems somehow intact posteriorly. So what should be the approach for this fracture?
The X-ray shows you a fracture going right into the SI joint. So this, and that's there on the 3D CT also.
Yeah,
So you have a fracture which is going right into the SI joint.
SI joint. But it is not completely separated with the axial skeleton. It is still intact. So Raju sir, how can you classify this fracture?
So again, do we have the 2D scans?
I have not searched
Because-
today.
Because there's a fracture line going right up to the, almost up to the crest, but not entering the crest on the 3D, and that could just be a feature of sort of averaging there.
Superior wall. So what should be your approach for this fracture?
Iliofemoral.
Iliofemoral.
Yes.
Yeah. Raju sir?
These fractures are extremely difficult to reduce. They look pretty, this thing, and there is an anterior dislocation also. So there might be some
Yeah.
labral buttonholing.
I think the posterior column is pretty intact in this case.
Yes, yes, yes.
And yeah,
Intact.
posterior column is intact. The whole of the, it's a, yeah, as Lord Nimade was saying, it's a anterior column, but you can't really say that it's an anterior column because the obturator foramen is intact. And yeah, it's a variant of called as a posterior wall fracture according to the books. But it's very difficult for our mind to understand that it's a posterior wall fracture. So best to put it as an anterior or superior wall fracture with a wing.
So there is anterior column fracture and the fracture is extending in the iliac bone.
Anterior column fracture going into posterior column part also, but the rest of the posterior column is
Intact. So
The fracture is somewhat like this. It goes like this. So it's the anterior column fracture here. It goes up here, but the anterior column is C. Otherwise, it looks intact because from sciatic buttress to civil continuity is maintained. Similarly, posterior, if you see the sciatic buttress to ischial continuity is maintained. So this is not posterior column. This is not anterior column. So which is the fracture? Which is not posterior column? Which is the not anterior column? Which is the posterior wall. And this, if you see from inside, it is like this. So the lateral classifies this as a superior wall fracture, which is a subtype of posterior wall. Even though, yeah, it can go in estrogen, but at the level of acetabulum, it is a superior wall.
so
It can go anywhere, it can go anywhere.
I think of all his series, which he had 700 some odd cases, he only found two patients of this variant. But I think we are lucky because in our generation we are seeing a lot of these fractures, but we don't know how to classify because Letourneau didn't classify.
Yeah.
So he called it extended posterior wall or whatever you call it, but the approach is anterior. Most of these are approached anteriorly. So calling something posterior wall and coming back from anterior approach is very difficult. So I think we are going to call this something like superior wall fractures, extended superior wall fractures.
so it looks like anterior column fracture with anterior hemitransverse. Hemitransverse.
So there is one Chinese guy. There is one.
Nothing like, but this one is a typical fracture.
There is one Chinese guy who has written a paper, and he has said this is the third column acetabulum called as a superior column. But since the fracture is so rare, we don't want to add a complexity to already anterior and posterior column. So better to.
Yeah.
It's very rare.
Anterior hemitransfer posterior column, okay, Letourneau mentioned it, but grouped it under T. That is
Yes.
not a separate entity.
So
Whatever name you can give, you can give.
So basically, it's an unclassified fracture.
yeah.
No, it's not unclassified. This definitely is this. They are classified, they are put in the category of posterior wall, which is difficult for us to accept. But by definition, if anterior column is intact and the posterior column is intact, then what fracture remains is the posterior wall only. But the posterior wall starts from posterior inferior, posterior, posterior superior and superior. So it is just pure superior wall fracture. But the superior wall fracture has to exit somewhere, and it exits way high in the iliac crest. That's why our mind tend to perceive it as an anterior column fracture.
Yeah.
Fracture has been explained in the textbook. Yeah, as a superior wall. But they are very rare, so we don't want to add that very complexity to already complex fracture.
Okay. So what should be your approach, sir? Pradeep sir, what is your approach for this fracture?
So this is iliofemoral. Now these injuries are extremely difficult to reduce. They look pretty innocuous here. मैं इधर जाऊंगा, ऐसा करूंगा, but they are extremely difficult to reduce this injury. We may have to complete that, and we have to use 2 or 3 shank spin inside the this thing to reduce it by iliofemoral approach if require capsulotomy, and fix it with 1 or 2 LC2 and 1 posterior column screw if require anterior column also, but multiple screws.
John sir, what's your opinion?
No, so I agree because you have to go anterior to fix this because from posterior you will not see it. No, but what I wanted to ask is if you follow the iliopectineal line, it seems to end somewhere and then you have the fracture there.
Yeah.
So how do you explain
No,
that if the anterior
either
column
model,
is not involved?
the fracture is just going and
So where does, so is it a rotational element?
no, the fracture is like here, inside here. The fracture is going somewhere like this. But if you see the sciatic buttress to pubic, what is the column? Column is the iliopubic continuity. And we have sciatic buttress to pubic continuity is there. That's why column is intact.
No, but I'm just looking at that AP X-ray.
Show the other X-ray.
I won't,
He has not.
so why are you getting this
It's because
appearance?
here, starting here, just below the bridge.
Because
it is green.
it involves the anterior column.
No, it's not.
Now it stays there. Because the only anterior 3/4 represents anterior column.
So
it doesn't involve anterior column.
We need to ask this question to ourselves. Number 1, is the ischium continuous with sciatic buttress? Yes. So posterior column is intact. Is the pubis continued with the sciatic buttress? Yes. Yes. We see on the top here, but from here it is continuous. From inside it is continuous. So that means anterior column is
So outside is not inside.
Yeah.
So, but my experience was a little bit different from the Pradeep sir. It was easy to reduce and it was very well reduced in very anterior AIP approach through the Estopa approach. I did this surgery. Patient was already, laparotomy was done, so there was another incision for that. And this was the part of pictures when I try to reduce the fracture. We put first of all the 1 interfragmentary screw to reduce the anterior column iliac fracture. Thereafter all things comes together and we buttress it through the plate. So this is the post-op picture, well reduced. This is the final picture. Fracture was completely united in follow-up, and this is my post-op protocol for the any acetabular fracture, and this is the result of the patient. Thank you, sir, for your patience hearing. So can I present another case, sir? Thank you.
No, thank you, Dr. Pravat. Thank you. Now this session is over. Now,
No, sir, I'm not.
oh no, Dr. Asli, please.
I'm not presenting.
No, you are not presenting.
So I would like to call Mahesh sir, NK Singh sir, and Ritesh Runu sir is not here to felicitate our case presenters. So, Dr. Shashikant Boss, Dr. Ratnesh sir, Dr. Prabhat Prakash sir, Now I would like to call Rakesh Rajput sir to felicitate our chairpersons.
Now we are coming towards the end of all the sessions. We'll have a small demonstration of putting anterior column and posterior column screws by all the faculties. And then we'll end the session here and we'll go to the bone saw models. First, I'll... John sir, I'd like to for a group photograph of the faculty and the organizing committee. Ranjit sir.
Thank you, sir.
First, I'd like to call Dr. Pradeep. Retrograde anterior column screw. Where is the model? Praveen.
The MIS in pelvic acetabular surgery, we have minimally invasive exposure techniques, we have minimally invasive fixation techniques. So since morning we have spoken about lot of extensile approaches and the approaches, how we can titrate them, how can we reduce the exposure minimally. Now we are going to go and see about what are the minimally invasive fixation techniques. So these are called as the column screws. So in acetabulum, what we call as called the osseous fixation pathways, OFPs. So if you see the pelvic bone, it's an innominate bone. It's an innominate bone. We really cannot make any shape of it. However, there are particular cylinders, bony cylinders inside the acetabulum, inside the pelvis, which we can utilize for screw fixation. Like in femur and tibia, we pass an intramedullary nail. So similarly, we can identify different cylinders placed at different points, and those we can utilize for a fixation, either screw fixation or not a nail definitely. Of course, some people use pens, but for a screw fixation, which roughly can be considered like a nail. Okay, so what are these osseous fixation pathways? So the one pathway is called as the posterior column. So starts from the ilium here and going into the ischium. That is one pathway. That is the posterior column. Another is the anterior column. Starts from the pubis and going into the ilium. So that is pivo-ilial fixation. So this is ilio-ischial and pivo-ilial. So we have these two osseous fixation pathway. On the top of that, we have the LC2 pathway, which in the morning we discussed, from the AIS to PSIS. So that is the LC2 pathway. What is LC2? LC2 is a lateral compression 2. So lateral compression fracture generally occurs like that. And to fix it, the screw are described. That's why it's called a LC2 fracture. There is nothing but the lateral compression. So this is another pathway to fix that. On the top of that, we have this iliosacral screw. So this is the iliosacral osseous fixation path. So these are the commonest osseous fixation pathway available. Apart from that, there are small minor fixation pathways which may be there, may not be there. So all these pathways which I have described, they are continuous pathways, and they are discontinuous pathway also. Such that it starts out, the screw goes in then out and then come in. So that's called as a discontinuous pathway. Sometimes the infraacetabular pathway, the screw which starts from here and goes all the way into ischium. This pathway can be continuous or sometimes it can be discontinuous. So these are continuous and discontinuous pathway. Another pathway is start from the iliac crest, out, in, then comes out and again goes in. So skewer method of putting the screw. So these are the different pathways. So we are going to discuss few common pathways. So I am going to discuss the retrograde anterior column screw. Dr. Rajput is going to pass the same screw antegrade, and then we have Dr. Meena who is going to demonstrate the posterior column screw antegrade, and Dr. Ashok Raju is going to tell us about the infraacetabular screw. So whenever we are doing a femur nail, we put a guide wire, and the guide wire we check in two views, AP and lateral, to see that the guide wire is inside the bone in both the views. Okay, so same way, any pathway, both the pathway, whichever pathway you take, they have AP and lateral view, but they are not plain AP and lateral view, because these pathways are placed in a different angle in the body, but they are the orthogonal view are available for each pathway. So you need to memorize which are the orthogonal view for each of the pathway. Okay, so that is point number 1. Point number 2 is the radiology dictum. And what is the radiology dictum of safety? To see that you have the one structure inside the other structure. To see that one structure is inside the other structure, whatever view you take, it should be seen inside. That is point number 1. Point number 2, if you want to see one structure is outside the other structure, there should be at least one view where you should see that the structure is outside completely. So in another view you may see it inside, but in at least one view you should see that it is completely outside. So that is the radiology dictum. 2 rules we need to keep in mind. Rule number 1, to see that one structure is inside the other structure, any view you take, it should be seen in. So if I have to see that my screw tip is inside the ischium, then any view I see, my screw tip should be seen inside the ischium. But if I have to see that my screw is not in the joint, then I need to at least take one view in which my screw is not seen inside the joint. So these views are different for different osseous pathways. So I am going to tell you the views, entry point, trajectory and views for antegrade anterior column screw. Sir is going to tell for the retrograde antegrade screw, and so on and so forth. So let's see the antegrade anterior column screw. So the anterior antegrade column screw is retrograde, my mistake. Retrograde screw starts from the pubis, goes into the ilium without going into the joint, without going in the vessels, without going in the bladder. Okay, so it should go all the way pubis like that. So the entry point of this screw is marked X here. So it is inferior and lateral to the pubic tubercle. So you just palpate the pubic tubercle, take a palpate that area, inferior and lateral to that, and that will be the entry point of the retrograde anterior column screw. So once we take that entry point, we don't want to take this entry point oblique because it tends to slip like that, because the surface is slippery. So you can just take one entry point like that, and then once that hole is made, then with the help of that hole you need to make. So now this direction is, if you are taking radiological direction, and sometimes you have already opened it and you want to take a clinical direction. So if you have already opened it, you already palpate the pelvic peculiar brim, and you can just go like that. If you want to take a radiological direction, then you need to put the pelvis in. So this is AP, so you need to put an obturator and slide of outlet view. What happens? In obturator outlet view, the entire acetabulum gets separated from the anterior column. So in this view, we need to see that our guide wire is not going inside the hip joint. Yeah. But if my wire can still go posteriorly, and in view you will see that it's not going in. So to check that, the orthogonal view need to be checked, and that view is the inlet view. So I need to take two views. An inlet view to check that my guide wire is not going posteriorly inside the bladder or anteriorly inside the vessel, and obturator outlet view to see that it is completely going inside the acetabulum and not going in the joint. And in that way, if I will cross the acetabulum and will exit into the gluteal pillar. Can you see? It will exit into the gluteal pillar. So this is the gluteal pillar. So that is the trajectory of the retrograde anterior column screw. So this is one trajectory. So we know that it starts inferior lateral and goes superiorly, posteriorly and laterally like that. We need to take two views, obtuse outlet view to see that it is not going into the joint, and inlet view to see that it is not going anterior posterior to the ramus. Any question in that? Okay. Sometimes the fracture is way here and then your entry point becomes very close to that. So in that case, we need to pass something called as a ramus screw, which is a screw where entry point is at the pubic symphysis, and we go horizontally like that, completely horizontally like that. And in this, we need to take inlet and outlet view to see that you are into the ramus. However, this screw will going into the joint. If you see, this will exit inside the joint like this. Okay, so that's why this screw needs to be short. If your fracture is too medial, this much length is enough. So in outlet view, you need to check, you need to stop short of the joint. So this is called as the retrograde ramus screw. So for retrograde, we have two trajectories, the retrograde column screw and retrograde ramus screw. Yes.
Right, so I think not everybody can explain things as beautifully as Pradeep does, but the surgery has to be still done. One warning I want to say, these are not easy screws. It's much better to actually open up, see for yourself and actually plate it. But there are cases where there are too many things happening in those patients. So you can then cut down on exposure if you are good at putting screws differently, like from front to back or back to front. So these screws actually help you. So you are doing something in the back, right? So in the posteriorly. And then you want to come and there is a transverse fracture. So all these screws which Pradeep has told you should be used for non-comminuted fractures. So make sure you don't screw up because you will actually compress it too much. So or you use a screw which will not compress but which will hold. But predominantly these are for so if you have comminuted posterior column but non-comminuted anterior column, so go back, fix your fracture and then put from front to back a screw. Similarly, if you are fixing anterior column and you want to go and fix the posterior column, and he's told you can do that. So my worry for today for you will be putting, how do you go, if you are in the back here operating, how do you put a screw on here? So there are two ways you can do that. Sometimes, as I said, you might have opened up from front also as like say if you've done an iliofemoral. So in that case, we've already told you what the screw we call is, from the front here we go in the anterior column. So just outside the anterior inflex spine, and you come out here, you again enter here and again go back inside here. Okay. So this screw is in, out here and again back in here. So that's the anterior column screw. So that's almost going this way, right? So basically you start here. So that's one screw. So can you see me entering outside? Is that yeah. So can you see that out now? Okay. Anyway, let me come out. So can you see that? Right? So you come out. So now you change the trajectory a bit and actually go in, okay? These screws only have that amount of space, 1.5 centimeter or so. So very easy to actually go. Now that's not our worry thing. What we are going to show today is how to come from behind. Now, when you are looking, so you are going to look at the same view which Pradeep was telling you. So you are looking at from sort of operator view and outlet view, right? Because you want to see this whole thing right on top. So that's the only view which you'll get. This is the gluteal pillar as we call it. So you can feel that very well. And normally we keep 2 finger breadth above that. So that's the sort of our exit entry point. Or sometimes we have to go even higher up. So you may take 2-3 attempts to actually find out what is your true entry. It's not same. People's inclinations are different, right? So, and our shapes are different. Corridors are different. So for one country they have about 2 centimeter corridors. we've done our corridors and there's only 9 mm corridor. So particularly if you're operating on a lady, we can't get 6.5 screws also. So anyway, so one of the screw trajectory will be somewhere from here. So you look at it, see all this is done on the Siam. So showing you on a model lecture doesn't make much sense, but so you go there and hopefully in looking at Siam, you should come back to where Pradeep has started. Yeah? Yeah? I'm actually cheating. So it's the same track which produces. But let's take a different track, right? Just for the sake of it. Now, that's a different track, okay? Is that visible? Yeah. Yeah? Yeah. So I'll deliberately come inside now, okay? So can you see that? So now if you looked at from the inlet view, you would make out that you are actually inside. Okay, it is still safer. So where do you want to be safer, inside or outside? So be sure that you are looking at each aspect of it. So you've got to do multiple exposures in these ones. So each screw carries multiple exposures. So be careful about how much you will exposing yourself. Okay. So once you've seen that you are actually coming inside, so you're going to change your direction. So now you're going to go inside. Okay. Again, you will check. Sometimes these wires don't let you actually change the directions very easily. So have a thicker wire, not a very small wire, okay? So have thick wires. Ultimately, you can swap again a thinner wire once you've done the thing. And many times, what we do is we actually start off with a wire once we are sure. After that, we tap the wire rather than actually drilling it. Okay? So let's check again where we are now. Right? So normally, when would I do Pradeep's method, when would you do this method? So if you have fracture which is somewhere below, right, and you're already doing something here, so it's better to come here. But if you have fracture on top here, which is closer to my trajectory here, I would do this, the anti-grade method, okay? So now even if I come here, it's not a problem, okay? So is that clear? Let me just come out and see. So this is a different trajectory we have taken. So the trajectory where Pradeep's was on 2, so you have to change sometimes, but you can adapt to it. You still have plenty of corridor. If you have wire which is thick, which won't deviate too much. So if you have thin wire, it will keep on going to the same place where you have gone once. So have a thicker wire which will allow you to change. So when I say what is the thickness, you want to be going about 2.5. So 2.5 should be the minimum thickness of the guide wire you need. So once you do that, and after that, you can measure, you can drill, and you can put a screw. So these are for fractures which are above this area. For below this area, you can actually come retrograde. But simple fractures, no combination. So is that clear? Yeah? So maybe the next one.
But how to reduce the fracture during?
Yeah, so fracture should be reducible by either push, pull, pressure, whatever, it should be reducible.
How to reduce? It should be reduced.
So that's another criteria.
Then
So
only how to do it.
one cumulative.
How to keep it reduced?
Yeah, so you need to keep some device, whichever you can push and keep it reduced. So it should be reducible. So most of these are done once you reduce, see, whichever columns you are doing, unless it's a T fracture where the two columns are behaving differently, you reduce one column, the other one reduces. And in majority of cases, one is displaced, the other one is not displaced from the beginning itself. It's just to stabilize more. What we have learned in pelvic acetabular trauma over the last few years is that don't leave fractures just like that. They all add to stability because you want to mobilize them early. So we add actually a bit more, we spend more time in OT by putting all these screws so that we can mobilize them early. Okay? I think you can put
just to answer your question, not for the reduction purpose, just to avoid exposure just for the fixation purpose. I don't want to expose just to fix.
So,
For reduction, if reduction is coming, not coming, we have to expose.
So I think the Dr. Pradeep has...
One column is fixed and naturally most of the time we get reduction. Then we pass it. That's it. It's not that you start with the key, I will fix it with the screw. Both column, one column is fixed, usually in transverse, the anterior column gets reduced. So we pass a screw, either retrograde, antegrade, whatever way.
So I am going to speak about that anti-grade posterior column screw. So I think this is the not a percutaneous screw. We usually have to open the lateral window. Means at least we have to open the 3-4 centimeter of that lateral window. After that, so this is used mainly in cases like whenever there is ACPHT pattern, transverse fracture, T-type fracture, means we are going to operate them through the anterior approach, and you don't want to go posteriorly by opening through the KL approach. In these cases, you can use the anti-grade posterior column screw either through the plate or out of the plate. So there are two views that are important for doing the posterior column, anti-grade posterior column screw. One is that is the iliac oblique view, which showing the complete profile of the posterior column, including from the ischium to the sciatic buttress area. So with this view, you can confirm that your screw is in the posterior column and out of the joint. So and another view that is important is the obturator outlet view, in which you can see that your screw is in the ischium area. But in this view, it will seems in the joint, but it's posterior to the joint. And for the entry point, it's usually there is a wide area of entry. You can from it's around 1 to 2 centimeter lateral to the anterior SI joint, and slightly 1 centimeter anterior to the SI joint. So it's anterior and lateral to the SI joint. So there you have to make a circle in that area, and in that through that corridor you can put a posterior column anti-grade screw depending upon the fracture pattern. So always try to put a screw in that should be perpendicular to the fracture. So you can change your trajectory slightly depending upon the fracture pattern. So for starting, we have to make a circle in that area. Yeah, this one. So this is the area for entry in the for posterior column anti-grade screw. And the first view for starting the entry point, you should take a iliac oblique view. And there are angles have been mentioned in the literature that this one should be the angle, it's around 30 degree from the coronal plane. But you can adjust the angle depending upon your C-arm views. So this is the area where we start with the entry. Sorry. So it should be done in the supine position. Means while you are treating ABC, ACPHT, transverse or T-type fracture through the iliofemoral approach, then you can after reducing the posterior column, you can put the anti-grade posterior column screw. Yeah, direction should be towards the your direction should be towards the ischium. Yeah. And first you will see that iliac oblique view. Yeah, this one. So this area will be visible in the iliac oblique view, and here is the joint. So you are behind the joint and you are going towards the ischium. So this is for the this is the way you go in towards the ischium. Then you will take a AP view, and in AP view it should be bisecting the acetabulum. Yeah.
Position, because the position of your hand and the respect of your position of the patient is very difficult.
So patient is supine. It's quite difficult to do in obese patient because you may not get the adequate angle. Yeah, that is difficult. But
that's why I'm saying.
You can use a thick sleeve while doing putting the guide wire.
In obese patient, we can start from the iliac crest only for higher posterior column fractures, which are.
Yeah.
Not iliac crest per se, but is a different trajectory you can start. But also is a different trajectory.
Yeah, they have been also described from the that iliac crest to the posterior column, but that is for the high fracture. But whatever the described anterior column posterior column screw is through that.
But entry point, will you make it through the IIGB or through any body?
No. It should be there is a large surface area. There is a
So I think for all the beginners, what Pradeep is saying is for an experienced person. So just put a wire around here.
Yeah, parallel to the
So you can
quadrilateral.
feel the ischial spine when you put your finger. So just put one wire on ischial spine, you are just 2 centimeter behind it. And that way, and if you go parallel to this wire, you are almost there. Okay, so just leave this wire as a guide for you.
So again, the two views are important. One view that showing the all the guide wire should be in the bone, and in one view that showing it should be out of the joint. So these are the two important things. And usually it doesn't require to go till the ischial tuberosity. Usually we needed to cross the acetabulum area. So we can get a screw of around 100 to 110 centimeter of mm of the length. No. We have, after putting the guide wire, you can measure easily. They usually go between 90 to 110.
What is the normal expected range?
So it's not percutaneous, it's minimally invasive. We are going through the lateral window. For retrograde, you can go percutaneous. For antegrade, any kind of anterior column screw, you can go percutaneous. For doing the antegrade posterior column screw, you have to open the lateral window. And it is one of the most commonly used screw in the acetabular surgeries, because in most of the patient, while we are going through the anterior approach, doesn't want to go posterior, you can put a screw through the plate or out of the plate.
The same approach. The approach is the same. The supralateral window. You are using that approach and fixing the.
Yeah. So. So this is how it looks like. So this is the behind the joint. So when you are going for the iliac oblique view, it will seems behind the joint. When you are taking AP view, it will in the joint, but we are behind the joint. And when you are taking obturator outlet view, so it should not come out through the posterior wall. So that is also important to measure the length. Means if you are seeing AP, it seems like you are in the bone, but when you take the obturator outlet view, somewhere it may comes out in the posterior wall. So you have to titrate that adequate corridor. In see the iliac oblique view, it should be out of behind the joint, out of the joint. When you are taking AP view, it will usually bisect the acetabulum. And while you are taking the obturator outlet view, it should be in the ischial tuberosity area. Thank you. So, Dr. Ashok Raju, he is going to speak about that higher fractures. So means if you are doing for a higher fracture, you can start from the iliac crest area, and if the fracture is near somewhere near that this area, high fracture. Again, this will go same kind like in out in technique. It will go in, it will comes out. And it will come out near that ischial spine area. It will not going towards the ischial tuberosity. It goes nearby the ischial spine area.
why are we talking about the infra-established screw? That is because and a long column screws like this. Okay, your fixations, you can see one fixation here, one fixation in your posterior column, and then you have fixed it well with screws across this. Okay, so you have a very good fixation on the apex of this acetabulum. When you have a fracture extending down into the base of the acetabulum and then exiting out, you want to close that in certain fractures when they are grossly comminuted over here. Otherwise, the fixation is on the top, it can still open up like this. Okay, to close that and have a periarticular fixation, that is when this fixation of infra-acetabular screw has started to give a more stability. So you have a fracture fixed here with plates, you have long column screws or plates, column screws, you have screws passing from the plate from the anterior column into the iliac wing. So you have a 3-point fixation here. You are adding one more fixation at this level to prevent it from opening up. So this is the use of the infra-acetabular screw. So how do I put this infra-acetabular screw? So for the infra-acetabular screw, for the infra-acetabular screw, you need to do through a stopaz or iliofemoral approach. Okay, you can't do it with any other approaches. So your entry point is, this is the iliopectineal eminence, what you can see. So you have to go a little down or anterior and then around a centimeter and odd, and B, this is the superior pubic rami, this is the width of the rami, and B in the center of the rami. That is your point. Okay, that is your blind point intraoperatively. Then you take a obturator view, and then once you take an obturator inlet view, what you do is, okay, how do I show? This is the obturator view, and this is the inlet view. So once you take an obturator inlet view, your teardrop, this is the teardrop, you will see an end-on view of the teardrop. You have a marker pin or something? Okay, fine. So when you take a obturator inlet view, you see a end-on view of the teardrop. This end-on view teardrop is the one which goes down like that. So the first point, this is the iliopectineal eminence. You go anteriorly and be around a centimeter and be in the middle of the root of the superior pubic rami. That is a arbitrary mark. Then you take an obturator inlet view and see the teardrop. That is an end-on view of the teardrop. That is exactly your starting point. Yes? Then you keep that point over there, or make a drill hole with, if you are using a 3.5, make a 3.5, take a 3.5 drill bit and make a hole over it. Don't go through and through, but make a bigger hole and use a 3.5 screw. And then you take an obturator outlet view, and this is the direction in which your screw. What? Wire, okay. Oh, it's glaring, fine, take it. So once you take that view, you will find that it's almost like a vertical placement of your screw. Yeah, this will tell that you are inside. Okay, this is the trajectory with which you should go. Then you take a iliac view. Iliac view, Yep. Here. And an iliac view will tell that you're along the border of the obturator foramen rather than being too inside or too outside. If it goes like this, that is the point. So I am taking a point here in the center, a little anterior and center of the pubic rami, and then I make an entry point with a 3.5. If I make with a 3.5 outer cortex, and then I have place for my 2.5 drill bit to manipulate a little bit here and there, and then I will take a obturator outlet inlet view to see the dead on point of the teardrop. I take that point, take a obturator outlet view, and then go inside in the direction to see the direction of my screw, and then an iliac view to see that I am inside the lateral wall. Okay. So this is the length of the screw. Yeah, there are issues. This is around 80 to 90 centimeters. Generally, this screw is 80 millimeters. Sorry, 8 centimeters. Yeah. Okay. And very important, it is very difficult to put in females who are very, especially in females, because they have a very narrow superior pubic rami. Not only that, what happens is that you have the obturator vessels which are going inside. This is the foramen. So based on your thickness of your teardrop, if your teardrop is thick, then you have no issues in passing this. Everything will be inside your osseous bone. But if it is very small or a very thin teardrop, then it will pierce the outer cortex, it will go through the superior pubic rami, and if you are inside, it will go outside. It will not go inside, it will just be outside. And if you are too out, means on the outer aspect of the ring, then you can go through the inferior part of the acetabulum. So you have to be very careful, especially in people who have very thin teardrop and especially in females. Yeah. That is the limiting factor in this.
Okay, so before we depart, I think we need to discuss something about the SI screw. Now, SI screw is a very commonly screw, and one of the, if I have to choose, I think one of the easiest screw to pass would be the SI screw. So if you see the SI joint here, we see a sacrum over here. So we have a sacrum over here, and if we put the sacrum inside inlet view, we can see that the anterior part of the sacrum really does not take part into the projected trajectory. If you have to project the trajectory like that, the anterior part, it's kind of wings here. So this anterior part is not useful here. Can you see? Yeah. In outlet, it is pretty easy that you need to be above the sacral foramina and into the and below the disc, that is this thing. And one of the most important thing that you need to take is something called as a lateral view. In lateral view, we have a radiological entity called as the iliac cortical density. Now, if I have to dissociate this ilium, I don't know whether I cannot. Okay, anyway, if I have to dissociate the sacrum, I'll see the sacral projection something like this. Okay, this is the sacral projection. However, what is the most important structure that pass here is the L5 nerve root. The L5 nerve root, after coming from the L5, goes like that. And if you see, it passes much more posterior to the anterior edge of the sacrum. If you see, the L5 nerve root will be somewhere over here, and the anterior edge will be here. So if you see the lateral projection, the L5 nerve root will be somewhere over here, right? And fortunately for us, this part of the sacrum impart a shadow here, curvilinear shadow, like this. This is called as the iliac cortical density. So if you take a zoom in here, please zoom in. Yeah. So if you take a lateral view of the sacrum, we will very characteristically see a line here called as the iliac cortical density. So we need to be the entry point has to be posterior to the iliac cortical density. So first thing, we need to take a lateral X-ray. We need to see that the ICD on both sides are matching. Sciatic notch on both the sides are matching. So that means we are getting a true lateral view. In true lateral view, we need to start just posterior to the iliac cortical density. And that way we are going to be safe. That is the safe entry point. So that is regarding the entry point. Next comes is the trajectory. So once you have taken the entry point, ideally I take it with the owl. So you take an entry point and just stop there. Then you take a lateral inlet and outlet view. Then inlet view, you see where is the projection of that KY, whether it is going posteriorly, whether it is going anteriorly. Okay, so we need to be in the center of the sacrum. Similarly, when you take an outlet view, we need to see that we are going above the S1 foramina. So like that we need to go. So we need to start and we need to go all the way without going into the S1 foramina. We need to go like that. So keep on checking in the inlet and outlet view, and that's the way you forward. So this is a straight trajectory for the SI joint, for the sacral fracture. But for SI joint, it is little bit tricky because the SI joint is like that and we need to go posterior to anterior. So entry is much more posterior here for SI joint, and from then onwards we direct little bit anterior and we go, and this screw will come out somewhere here. Okay, so these are not continuous through and through screw. This will stop short at the midline because no, I am not going galat. This is correct only, but because I am starting posteriorly. This is for SI joint. Yes. So this is posterior to anterior. This is posterior to anterior for SI joint. No. So the initial trajectory was center to center, and this was going all the way like that, whereas this was anterior to posterior. Okay, so next. It can be done in supine or in prone. Okay, so the last trajectory is called as the LC2 trajectory. Okay, from the lesser sciatic notch till the PSIS. For this we need to take 3 views. And the first view is called as the obturator outlet view. Okay, so now it's difficult to describe, so I'll try to show in my mobile if you can zoom. Okay. Can you zoom into this? I don't know whether you, good. So when you take an obturator outlet view, you will see a inverted teardrop kind of a thing like this just above the acetabulum. So that is a obturator outlet view. So an entry point has to be in the center of this obturator outlet view. So that's the way you take entry with the owl. So you take the entry in this is after putting the screw, so you are seeing like that. And then you need to take 2 views. So this is the entry, and then you need to take 2 views called as this is obturator inlet view, where you see the inner cortex and outer cortex, and your screw has to go in between like that. And another view is the iliac view, wherein we need to see that the screw is not going into the sciatic notch and going above this. So let's discuss this on the model. So first we need to take an obturator outlet view, where we will see the teardrop at the teardrop or at the lateral margin of the teardrop. We need to take the entry. Now this is the apex of the triangle. If you take at the entry here, it will tend to slip. So try to be on the lateral aspect. In the lateral aspect, it's much more safer. So just palpate with the tactile feedback and then just slide laterally, you will be safe. Because you don't want to slip medially and go towards the vessel. So you want to go laterally safe. So that is the entry point. From there, you turn the Siam into obturator inlet view so that you see like this. And then you tend to go all the way down like that. And once you are at the sciatic notch, you need to see sciatic notch. You need to see that you are not going to the sciatic notch. And then you go all the way down. It should come at the PSIS level, somewhere here. So this screw length is roughly 140 to 150. So before you put this screw, you make sure that those long screws are available, because you pass those such beautiful long screw and then the longest screw available is only 100. So before you want to pass this screw, you make sure that those screws are available with you. Okay. Okay, so this is regarding the LC2 screw. Thank you.
Dr. Rajiv Anand, sir, and Dr. Rakesh Rajput, sir. Sir, kindly come and felicitate Dr. Rajiv Anand, sir.
So I think on behalf of AOPAS, I really want to thank the Bihar Orthopedic Association and Dr. Rajiv Anand in particular being chairman, and also Ashwin. Ashwin, you've done a wonderful job. As I said in the beginning itself, that I just saw about 5-10 people when we did about 10 years ago, and today there are more than 100. So it's a huge change we are seeing. An interest, and it's not just in Bihar, in all over India, that this stream has got its due importance at last. It reflects a lot on the teachers we've had all over India. Initially, we had only 3 people who could actually teach in India. When I started learning in India, only Dr. C.J. Thakkar, Dr. Ramesh, and Dr. Magu. There wasn't a 4th person to actually teach us. So it was very difficult. So when I came back from fellowship, but today you have so many, and the youngsters themselves are teachers now. So, and this is a stream which belongs to young people. So we want more and more young people to do this surgery, because the senior ones are all going to go and start doing joint replacements. So it's better that the young guys come in. It requires a lot of effort. And Dr. Rajiv Anand, where is he?
And thank you, sir. And I hope that in our next upcoming pelvic course, you will keep coming and enlighten your knowledge and share your knowledge with us. Felicitate our young and dynamic organizing secretary who has done so successfully this acetabular course.
Last time भी हम लोग का अच्छा attendance था. At
Now-
that time you also were लेकिन इस बार लोगों का knowledge था और
Now, Anand, sir, to kindly come and felicitate Praveen Sahu, sir. Praveen, sir. Vidya, are you here? Next, Dr. Vidya Sagar. Next, Dr. Sunny. Vikas Bosch. Vikas Bosch. Next, Dr. Amrit, Dr. Vikas Kumar Boss. Next, Dr. Rai Amrit Nath Sahai. Dr. Upender Kumar Bose and Dr. Ramakant Bose. Please kindly come on the dais for a few minutes. Ramakant Bose. And lastly, Dr. Ramakant Bose. I will end the conference today with a vote of thanks, and I am deeply indebted and thankful to all my national faculties who took their time from their busy schedule to come to Patna and teach us a lot of things on acetabular surgery. As we all know, this is an upcoming branch of acetabular surgery, so it is no less to thank all the delegates who came to attend this conference. I am thankful to my BOA President, Dr. Ranjit Singh sir, BOA Secretary, Dr. Mahesh Prasad sir, our organizing chairman, Dr. Rajiv Anand sir, for allowing me and helping me in arranging this conference, which would have not been possible without their support. I would like to thank my regional faculties, Dr. Shashikant Bose, Dr. Ramakant Bose, Dr. Prabhat Prakash Bose, Dr. Ratnesh Singh Bose, Dr. Rajat Chanan sir, Dr. Anand Bose, and so many more. I would like to thank my colleagues, Dr. Praveen Sahu, my senior Praveen Sahu sir, my colleague Dr. Vidya, Dr. Sunny, and Dr. Amrit, and Dr. Vikas Bose. Nonetheless, this workshop which we are all attending has been possible due to contribution and help from Nebula Surgicals, for which they provide special plates for acetabular surgery and supraperitoneal and infraperitoneal plates. The pharmaceutical companies, I am highly indebted to them for helping this program to be occurred, especially MSN, Lupin, Pharmed, Alchem, Edtas, and Ribanta Pharmaceutical. Lastly, Moria Hotel and its all staff and members helped a lot. Ashish ji, Dharmender ji, and everybody. And at the end, our own BOA staff, Chandan and Uday, who helped me a lot during the last 1 month in arranging everything for today. Saima and Hari ji for attending the photography and the audiovisual. Thank you so much. Thank you so much. Thank you.